Afternoon, everyone. Thank you for joining us. Um, we'll give it a few more minutes here. Looks like people are coming in, and we'll get started. Okay. All right. So we can go ahead and start. So good afternoon, everyone. My name is Biwat Arishai. I go by Paul as well. I'm currently a third year neonatology fellow at the University of Southern California and Children's Hospital, Los Angeles. I will be starting my cardiology training next year at Cincinnati Children's. We also joined by Rana Hussein as well, who's been our education curator for the physiology curriculum here. So welcome to Big Dreams for Tiny Hearts. We're a joint collaboration with the training and early career neonatologist, TCAN, and also SOCC, a section on cardiology and cardiothoracic surgery. We aim to create a joint national curriculum through our collaboration to address the complexity of the care for neonatal cardiac care. So we're also gracious to be hosted by Harvard University, so you can go there to the website and see all our previous sessions and complete online modules as well to learn more. For our next month, so starting now, for the next few months, we will be focusing on the physiology of congenital heart disease. So I'm really happy to introduce you to our speaker today, Dr. Laurie Armsby. She is currently a professor of pediatric at the Oregon Health and Sciences University. Her clinical specialty is in interventional cardiology. She completed her medical training at the Stanford University Medical Center and her pediatric residency and pediatric cardiology fellowship training at the Boston Children's Hospital. She also has been the director of the Pediatric Cardiology Fellowship here at OHSU since 2006. Dr. Armsby is also a past president of the Society of Pediatric Cardiology Training Program Directors, co-director of the AAP Specialty Review in Pediatric Cardiology Review course. And she also been a cardiology educator for the Specialty Review in Neonatology Review course as well, which is when I met her. Dr. Armsby, was so delighted to have you here with the Big Dreams for Tiny Hearts initiative. So without further ado, I'll let you go ahead and jumpstart our physiology curriculum. Just a quick reminder, though, if you have any questions throughout the presentation, please leave them in the Q&A box, and we'll have a Q&A at the end. Thank you.
Thank you very much, Paul. And thank you to everyone at Big Dreams for Tiny Hearts for inviting me to give this sort of three-part lecture. I have no disclosures. I wanted to say that we're going to start with the basics, and we'll work up to more challenging content. So please bear with me if you find this beginning part very basic, too basic. The reason is that many of the neonatologists attending this have variable experience and exposure to cardiac physiology and the care of newborns with congenital heart disease. So I don't want to leave anyone behind. We will start with the fundamentals of normal physiology, and then we'll spend a lot of time talking about flow and resistance. And then we'll move to groupings of lesions that have similar physiology. And finally, we'll get to the complex stuff, which is the thing that really we need to go into more detail on, which is management of congenital heart defects. And really the objectives are that you'll feel comfortable walking to the bedside of a patient with critical congenital heart defects and feel comfortable with the physiology, defining it and thinking through it. And part of that is feeling comfortable with the principles that govern flow and resistance within the cardiopulmonary circulation, and then applying those principles to develop your management strategy. And specifically, really, and we'll talk about this mainly today, to apply the principles of resistance to therapeutically manipulate flow. So we'll just get started again with the basics. This is sort of how my diagrams look. You know the anatomy, the superior and inferior vena cava to the right atrium through the tricuspid valve and into the right ventricle. through the pulmonary valve and into the branch pulmonary arteries. And on the left side, I draw the pulmonary veins with this little scalloped appearance in the left atrium, the mitral valve, left ventricle, aortic valve, and aorta. And I wanted to spend a minute on the terminology just to make sure everyone's clear. So when we say hypoplasia, we're talking about a small or underdeveloped structure. It could be a chamber, could be a valve, could be a vessel or a structure. Whereas when we say stenosis, we're talking about something that's narrowed. Again, could be a valve or a vessel. There's flow going through it, but there's obstruction to that flow. And then atresia, we're referring to complete blockage. So no flow at all passing through that valve or that structure. All right, so moving to the normal cardiopulmonary circulation, there's only a couple slides on this, but it's really important because I think it's important to know what makes the heart, the cardiopulmonary circulation work the way it does. Because if it's aberrant, we got to get back to the normal. So there's just 4 principles, and the principles are that the pulmonary and the systemic circulations are separate, and that those 2 circulations are balanced. So that means that the flow to the lungs is exactly equal to the volume of flow to the body. And then those 2 circulations flow in series. So the volume of blood going out to the lungs becomes the volume of blood going out to the body, and then becomes the volume of flow going out to the lungs again, and etc. And then finally, each circulation has its own ventricle to power forward flow. And then we have so many congenital heart defects, so many different variations of defects. But again, the bottom line to our management is to restore these physiologic principles on the left side as best we can. The goal to do that is what drives the medical and also the surgical and transcatheter management of infants with CHD. So for example, truncus arteriosus. Remember, we have this big VSD. We don't have a pulmonary valve. We just have a single truncal valve coming off of the heart, which leads to the aorta, and the pulmonary arteries arise from the aorta. So in truncus arteriosus, before surgery, our management strategy is to try to maintain a balance between the systemic and the pulmonary circulations. And if we're unable to do that, then we need to medically manage the effects of that imbalance. And usually over time, it's a situation of pulmonary overcirculation. When we get to the operating room, the repair effectively separates the pulmonary and systemic circulations and creates the balanced pulmonary and systemic circulations that we have, and provides one ventricle pumping to each circulation. There's one more example, something a little more complicated. So pulmonary atresia with an intact ventricular septum. That leads to a hypoplastic right ventricle and ductal dependence for pulmonary blood flow. So before surgery, when we're in the NICU managing this patient, our challenge is to maintain a source of flow into the pulmonary circulation. So we'll start prostaglandins to try to maintain a balance, a healthy balance between the pulmonary and systemic circulations. And again, if we're ineffective at doing that, to medically manage the effects of an unbalanced circulation, whether that's not enough pulmonary blood flow or too much. And then when we go to surgery, the first step in repairing this patient is to create a stable source of flow into the pulmonary circulation, one that's not dependent on prostaglandin infusion. So that would be a right modified BTT shunt in this case. And the surgeons choose the diameter and length of this tube in order to create the appropriate amount of resistance to flow, which allows for a balance between the pulmonary and systemic circulations. And that's what we'll talk about a little later in the talk. So the bottom line is to understand the medical or the interventional treatment plan with any defect, we first need to understand which principles of the normal physiology are aberrant in that defect, and then restore those principles as best we can in our management. So the key to treating congenital heart disease, you could say, is to get the right amount of flow to the right place. And so we're going to talk next about flow. So the vocabulary we use at the bedside for these patients is QP, QS, the QP to QS ratio. Talk a lot about left to right or right to left shunts, that pulmonary overcirculation or insufficient pulmonary blood flow, maybe insufficient cardiac output or heart failure, and then ductal dependence for either pulmonary or systemic blood flow. And I really want you to be comfortable using, not just understanding, but using these terms when you're trying to explain physiology to a trainee or to your colleagues. So starting with flow. So the symbol for flow is Q, and QP refers to flow that goes through the right heart to the lungs or the pulmonary circulation. QS refers to flow going through the left heart and to the body or the systemic circulation. So QP, the volume of QP becomes the volume of QS, and so QP equals QS. And in the normal heart, the ratio of QP to QS, therefore, equals 1. When we have a left to right shunt, that means oxygenated blood leaves the left heart or the systemic circulation, crosses to the right, and returns to the lungs. So that means that the volume of flow going to the lungs is greater than the volume of flow going to the body. So QP is greater than QS. And when you put those numbers on top of each other to create a ratio, QP-QS is some number greater than 1. And clinical signs of this situation or excessive pulmonary blood flow, tachypnea, dyspnea, tachycardia, we might see diaphoresis, we may see poor feeding and therefore poor weight gain. On X-ray, we see pulmonary edema, cardiomegaly, and in our labs, we may see rising lactate. And this constellation of symptoms is referred to as congestive heart failure in the pediatric population. Right to left shunt means that blue blood leaves the right heart or the pulmonary circulation, crosses to the left, it bypasses the lungs, and joins the systemic circulation. So here we're saying that the volume of flow getting out to the lungs is less than the volume of flow going out to the body. So QP is less than QS, and the ratio of QP to QS is some number less than 1. And the clinical signs of a situation like this would be hypoxemia, cyanosis, tachypnea without distress, especially if the baby's starting to become acidotic. On X-ray, we see dark lung fields, usually a normal cardiac silhouette. And on labs, a rising lactate and metabolic and respiratory acidosis. So let's just put this to a question, kind of a bedside situation. We don't have ABS or anything like that, so just come up with your answer to this. So over the first 14 days of life, a newborn develops increasing tachypnea and mild retractions. His feedings are interrupted frequently and shortened overall due to fatigue. So his weight gain is poor. His saturations in room air are 96%. You do a chest x-ray and that shows cardiomegaly and pulmonary edema. And your echo shows a large BSD and a PDA. So this baby, you can imagine standing in front of this bedside, seeing this situation. These are clinical signs of which of the following? So the answer to this is a sign of a baby with pulmonary overcirculation, or the QP much greater than QS. So we're standing here talking to trainees or talking to our colleagues, and we're going to use the vocabulary that we use in congenital defects. So which of the following describes, corresponds to a baby with pulmonary overcirculation? We'll sort of work through this together. I know where you are in this, but we have defined a left to right shunt. We have pulmonary overcirculation. And so for left to right shunts, that means that the volume of flow to the lungs is greater than the volume of flow to the body. And therefore, QPQS is some number greater than 1. So the answer here is B. And just an aside for a second. So if some of you were confused because does pulmonary overcirculation mean that you don't have enough systemic blood flow? Or are those two things equal, pulmonary overcirculation, insufficient systemic blood flow? And the answer is not until the heart starts to fail. So the heart's going to compensate in the situation of pulmonary overcirculation in order to avoid a situation where you have insufficient systemic blood flow. So as blood is siphoned off to the lungs, the heart starts to increase its total output in order to provide sufficient oxygen delivery to the tissues. So it's going to increase its heart rate. If it can, it'll increase its stroke volume, and certain vascular beds will constrict so that the blood that is getting out to the body is directed to the most important tissue beds. Now, if eventually those mechanisms are not enough and oxygen delivery becomes insufficient, then the tissues are going to start to use anaerobic metabolism, and that's going to cause a rising lactate and metabolic acidosis. And this scenario is a lot of what we mean by a volume loaded heart. So let's talk about that, because I hear that a lot when we're rounding, and I'm not sure that it's always used in a way that people understand what we're talking about. So in the normal heart, we said that QP equals QS, and each ventricle and circulation manages the same volume of flow. So here's a normal heart, normal flow pattern. QP equals QS. Let's just put some numbers to that. So let's say QP equals 4 liters of blood every minute per meter squared is going through the pulmonary circulation. And QS, same thing, 4 liters per minute per meter squared is traveling through the systemic circulation. So this heart is handling a total volume of 8 liters per minute per meter squared. Now let's say we have a PDA or ASD, VSD, like in this picture. And let's say we have a left to right shunt with that, to the point where we have a QPQS of 2:1, or twice the amount of flow going through the lungs as is going through the body. So putting numbers to that, the QP is 8, the QS is 4. And you can see here that even though we've got blood going away from the systemic circulation, the heart has managed to increase its output to maintain a QS that's equal to the normal heart, 4 liters per minute per meter squared. But this heart is handling a total volume of 8 plus 4, or 12 liters per minute per meter squared. So the volume that this heart is handling is much greater than normal. And let's say that over time, the pulmonary vascular resistance, which we'll talk about in a little bit, continues to drop, or we give this baby oxygen and we draw more flow into the lungs, so that now we have a QPQS of 4:1, or 4 times the amount of volume going to the lungs as to the body. So here, just looking at our numbers, we have a QP of 12, we have a QS of 3. You can see the QS has started to drop because it's hard to maintain 4 when you've got a lot of blood siphoned off into the lungs. So a little bit of drop in QS, it may be enough to keep from anaerobic metabolism. It may not, but the point here is that the total volume of blood going through this heart is 15 liters per minute per meter squared. So these are the patients that we're really careful not to add unnecessary volume, because these hearts are preload stressed. So maintenance volume is usually well tolerated, but we do try to minimize fluid boluses, especially fast fluid boluses, because that will increase the volume into the heart chambers very quickly, cause them to stretch even more, and potentially to fail. And these are the babies also that we advance feeds gently, partly because of concerns for bowel perfusion in case because often the bowel is vasoconstricted as one of the tissue beds to constrict when the heart is trying to maintain cardiac output. All right, so enough about that. We're going to go back to where we were talking about shunts. So here's a different baby. I have a picture here of a different heart. So over the first 7 days of life, a newborn develops tachypnea, poor feeding, and poor weight gain. This baby's saturation is 65% in room air. Chest x-ray shows normal cardiac silhouette. The lungs are normal, other than the fact that they have dark pulmonary fields. And you get an echocardiogram that shows tetralogy of flow, which is what this diagram shows. So the clinical signs that we're describing here, this type of baby would you would categorize as having which of the following? And the answer here is that this baby is showing signs of insufficient pulmonary blood flow, not enough blood getting to the lungs, basically. So same baby, these signs of insufficient pulmonary blood flow correspond to which of the following terminology? We'll work through it again. Hopefully you see that this would be a right to left shunt. And babies with right to left shunts have a QP that's less than QS. And so the QP to QS ratio is going to be some number less than 1, and in this case, 0.7. So insufficient pulmonary blood flow is sort of synonymous with right to left shunting and a QP/QS less than 1. All right, so why is flow such an important concept? So important that we're spending most of the talk on it today. Well, when you have a lesion where the circulations are not separate, and that occurs in many of the different types of critical congenital heart defects. So when the circulations aren't separate, then understanding the relative volumes of QP and QS really helps us manage the patient. It's really critical to making decisions about management. So do we need to increase or decrease the pulmonary blood flow for this patient? Should we give a diuretic to manage excessive pulmonary blood flow? What is oxygen going to do to the balance of QP and QS that we have now? Can we feed the baby normally? Do we have adequate cardiac output for that? And do we need to be careful with fluid boluses? Those are a lot of the questions that we engage in when we talk about neonates with congenital heart defect, and really understanding the ratio of QP and QS is at the heart of knowing how to answer those questions. So when we have a defect, we might be anywhere on this spectrum of QP being very low relative to QS, or QP being very high relative to QS, or we may be perfect, well-balanced circulations. How do we know where we are on that spectrum? We use clinical signs, like in those questions that that we just reviewed. Physical exam is really important. Our breathing, the effort of breathing, where the liver is, whether it's congested or not, etc. We look at chest x-rays and our arterial blood gas. An echo is going to be helpful. It's going to tell us the direction of flow through the shunts. And also it gives us a sense of chamber enlargement. The more flow through a chamber, the larger it tends to be. So that can be helpful, but it doesn't tell us exactly what the QPQS is, or the volumes really of flow through a shunt. Oxygen saturations provide clues, and we're going to talk about that a little later. But when we need certainty, when we're going to make therapeutic decisions based on this, then we can calculate the QP and the QS using the Fick equation and know it as certain as we can possibly be. So we're going to talk about the Fick for a minute. Cardiology, the cardiologists in this group need to know the Fick equation for your boards and for practice. Neonatologists, I think it's, if you understand what the Fick is and how we're calculating QP and QS, I think you'll understand the physiology of these patients better. And like anything, the more you think about something, the more you practice it, the better you are at it. So I encourage you to really feel comfortable with the Fick equation and to teach it, which will, again, make you feel more comfortable. So really breaking down the Fick, what it's saying is that the cardiac output times the oxygen delivery. So the oxygen delivery is equal to oxygen consumption. That's homeostasis, and that's the basics of the Fick. We can substitute cardiac output for QP and QS. That's flow going through these circulations times the oxygen delivery equals oxygen consumption. And again, QP and QS, what that means is it's the actual volume. It's the liters of blood passing through the pulmonary or the systemic circulation every minute. So we calculate QP and QS. We have an equation and we calculate it. We measure the oxygen delivery and we're given the oxygen consumption. Initially, it was measured somewhere, and now we have equations for this, for oxygen consumption. And here's the fix. So when we rearrange that equation, we get QS equals oxygen consumption divided by the oxygen delivery to the systemic circulation. And QP is oxygen consumption divided by the oxygen that was picked up in the pulmonary circulation. So again, this denominator here, oxygen delivery. Another way to think about that is that it's the change in oxygen content as the blood flows through a circulation, either the systemic or the pulmonary, the change in oxygen content. So QP, we think about oxygen consumption divided by how much oxygen was picked up as the blood passed through the lungs. And in order to know that, we look at the pulmonary vein, the oxygen content in the pulmonary veins, the blood coming back from the lungs, minus the oxygen content in the blood going to the lungs. The difference in those two numbers is how much oxygen was picked up as the blood passed through the lungs. For the systemic circulation, we're looking at how much oxygen was delivered to the systemic circulation. So the two numbers, or the two areas we look at, is how much oxygen was in the aorta as it went out to the body, minus how much oxygen was in the superior vena cava as the blood came back to the heart, returned to the heart. Sometimes we have an ASD with flow across here, so we can't use the right atrium. We tend to use the superior vena cava. So again, how much oxygen was dropped off as the blood passed through the heart, through the body. And the equation is the oxygen content in the aorta minus the oxygen content in the SVC. Now, what is oxygen content? How do we know oxygen content? Well, oxygen content in a sample of blood is the oxygen carrying capacity of that person. Everybody has their own oxygen carrying capacity, and it's based on how much hemoglobin we have. So how much the hemoglobin concentration is for that patient, multiplied by this factor. And this is a factor that is a constant that says how much oxygen each hemoglobin molecule can carry if it was fully saturated. So the product of these two numbers is the oxygen carrying capacity. And then when you multiply that by the saturation, the percentage of hemoglobin that's saturated in that blood sample, that tells you the oxygen content of that blood sample. Okay, so putting that into the equation, pulmonary vein sat times the hemoglobin times 1.36 minus pulmonary artery sat times the oxygen carrying capacity. And the same thing down here for QS. Okay. Now, when we want to measure or calculate QP/QS, or the ratio, we take QP and we multiply it by the inverse of QS. That's how you divide fractions. And so we cross out a bunch of things and we're left with a simplified equation that has 4 numbers in it. So QP/QS can be calculated by the aortic minus SVC sat divided by the pulmonary vein minus pulmonary artery saturation. All right, now the QP/QS tells us the direction and the volume of shunting. And let's just go through this for a second. So if there's no left to right shunt, normal heart, no shunts, then think about it. The blood coming back from the body has a certain saturation, let's say 70%. It travels through the right heart. There's no shunting. And so that blood has the same saturation as it heads out to the lungs, the pulmonary artery saturation. So the SVC and the pulmonary artery saturation is the same in patients when there's no left to right shunt. When there's no right to left shunt, then the saturation in the pulmonary veins, let's say, is 100%. It travels through the left heart, and in the absence of an infusion of blue blood anywhere, the saturation in the aorta is exactly the same. So those numbers are the same. So if that's the case, there's no shunting anywhere, the aortic and pulmonary vein sats are the same, and the SVC and the pulmonary artery sats are the same. These numbers are going to be the same, and you have a QP/QS of 1. Let's say there's a left to right shunt. Let's say it's an ASD with the left to right shunt. So the blood coming back from the body, again, saturation 70%, but now you have this infusion of red blood joining that blood in the right atrium, and together this blood passes into the pulmonary arteries. And this saturation is going to be higher than the SVC sat by some number. In this case, it's 85%, whereas the SVC was 70%. And so when you put the, let's say there's no right to left shunt, just a left to right shunt. So we put these 4 numbers into the equation. Again, aortic and pulmonary vein sats are the same, but we put these numbers into the QP/QS and we get 30 divided by 15, or a QP/QS of 2 to 1. So again, some number, a QP/QS greater than 1 is a left to right shunt. This number, 2 to 1, tells us that twice as much volume is passing through the lungs compared to the systemic circulation. All right, now in the situation of a right to left shunt, our aortic saturation is not going to be the same as the pulmonary vein sat. Let's say our lungs are normal and the blood coming back from the lungs is 100% saturated. Goes into the left ventricle, but here we have a VSD and there's blood coming across the VSD joining the blood coming back from the lungs. This situation causes a decrease in the saturation in the aorta so that it's 90 degrees, let's say. Let's pick that number. So here when you put, and again, there's no left to right shunt, so the SVC saturation is the same as the pulmonary saturation. So we plug these numbers in and we have an aortic saturation of 90 and a mixed venous or SVC saturation of 70. That is 20, divided by pulmonary vein of 100 minus 70 is 30. So that would be 20 divided by 30, or a QP/QS of 0.66. This is telling us that the volume passing through the lungs is 2/3 of the volume that passes through the systemic circulation. About 1/3 of the volume coming back from the body passed over to the body. And so less flow is going to the lungs. So really that's how when we're putting these numbers to a clinical situation, we're really thinking about the flow, how much is going through the shunts, how much is going to the body, how much is going to the lungs. And this second concept is really critically important. So we know that flow follows the path of least resistance. And so I want to talk to you about how this principle drives the pathophysiology that we see in congenital heart disease, and how we use these principles to manipulate the flow when we're trying to manage some of these defects. Okay, so shifting gears, we went from flow now to resistance, but they work in concert. So resistance is a major determinant of the direction and quantity of flow. So this picture, we have a PDA. How much of the flow coming out of the right ventricle crosses the PDA and goes to the aorta versus goes to the pulmonary arteries is determined by the resistance. And there's two laws that govern resistance: Poiseuille's law and Ohm's law. So we're going to go one by one. Poiseuille's law is resistance is proportional to 8 times viscosity times length divided by pi r to the 4th power. So here on our graph, we have a low resistance to high resistance. And as the viscosity and length of a structure, viscosity of fluid or the length of a structure increase, we have increasing resistance. But because the radius is in the denominator and to the 4th power, it has a huge impact on resistance. So when we have something with a low radius, a small radius, that is going to have a high resistance. But as the radius increases, the resistance drops significantly. And so the resistance to flow through a passage is highly dependent on the radius of the passage. So a question here, we have a 3-week-old. Here's a picture of a complete AV canal. It shows signs of pulmonary overcirculation, including tachypnea, tachycardia, tachypnea, high saturation, and a rising lactate. He's not gaining weight. And so which of the options below is the most appropriate interventional option? Do we want to dilate the pulmonary valve, start a prostaglandin infusion, or narrow the main pulmonary artery with a PA band? And the answer is we want to increase the resistance to flow to the lungs because this baby is showing signs of pulmonary overcirculation. And so if we narrow the MPA with a PA band, we decrease the radius and will significantly increase the resistance to flow so that more flow crosses the VSD and goes out to the body. Here's another practice question. This is pulmonary atresia with an intact ventricular septum. I showed you that picture before. So this baby is on prostaglandin infusion. His saturations are high and his blood pressure is 75/20, tachypnic, tachycardic, lactate rising. Which of the following is true about this clinical picture? His ductus might be closing. He's maybe developing sepsis. The amount of pulmonary blood flow is insufficient, or the amount of pulmonary blood flow is excessive. The answer here is the amount of pulmonary blood flow is excessive, but let's take it one by one. So the saturations are high. This is telling us his saturations are 96%. If he has blood coming back from his lungs that are 100% saturated, blood coming back from the body that's lower, 65% saturated, if the volume of blood coming back from the body is equal to the volume of blood coming back from the lungs, the saturation will be somewhere in between these numbers, close to average. The fact that it's so high and so close to the amount of flow coming back from the lungs tells us that the volume of flow coming back from the lungs is way greater than the volume of blood coming back from the body. The blood pressure is telling us that this low diastolic, he has a lot of runoff out of his aorta, especially during diastole. And these numbers are telling us that he has pulmonary overcirculation. So that's how we would get to this answer. And so what are we going to do about that? What intervention might help? Well, if we want to decrease pulmonary blood flow, we would increase the prostaglandins, decrease the prostaglandins, or give a bolus of normal saline. And the answer is to decrease the prostaglandins, to narrow the ductus so that the restriction is greater through the ductus and decreases flow. We'll finish with Ohm's law, which is that the Ohm's law tells you that the resistance through anything is equal to the change in pressure divided by the flow. So resistance to flow through a circulation is inversely proportional to the volume of flow going through that circulation. And so pulmonary vascular resistance specifically refers to the resistance of flow as it passes through the lungs, and PVR decreases after birth. Systemic vascular resistance refers to the resistance to flow as it passes through the body, and we know that SVR increases after birth. So how do we use resistance in clinical practice? Well, just as we manipulate the factors in Poiseuille's law to regulate flow, we can also manipulate the factors in Ohm's law to do the same. So if we want to decrease the resistance, we'll increase the flow. If we want to increase the resistance, we'll decrease the flow. And so we're running short of time, so I'm going to just leave this up for you and go through it really quickly. If we want to increase pulmonary vascular resistance, we want to vasoconstrict the lungs, and we might increase interstitial pressure, so mechanically ventilate excessive PEEP, things that we don't have much control over, lung hypoplasia, like for congenital diaphragmatic hernia or prematurity. Or if we want to decrease PVR and increase flow, we would vasodilate the pulmonary bed with these interventions. And so really quickly, if we have this baby with pulmonary atresia, intact ventricular septum, who's ductal dependent for pulmonary blood flow, what do we do if he has pulmonary overcirculation and we've decreased the prostaglandin dose? So we've tried to narrow this ductus a little bit. What could we do to balance the circulations? Start an infusion to raise the blood pressure, intubate and either do controlled hypoventilation or hyperventilation. And the answer is intubate and paralyze and hypoventilate, which will drive up the PCO2 and cause pulmonary vasoconstriction, which will decrease pulmonary blood flow. And then lastly, if we've done all of that and we go to the cath lab with this baby, what would we be doing there in the cath lab to try to decrease pulmonary blood flow and balance the circulations? And the answer here, sorry to run through it so quickly, but I want to stop on time, is to stop the prostaglandins, allow the ductus to get even smaller, and then to place a stent in that ductus that's a size, a radius that's going to restrict flow to the point that it balances the circulations. All right, so that's the end of this section, this first talk, and we'll the next two talks, we're going to talk about the groupings of defects that fit into the different physiologies and then on to management.
Perfect. All right. Thank you so much, Dr. Armsby. Really educational. I've learned so much from hearing your talk here. And just to, quick reminder, anyone, I see the Q&A here is really live and great. We have some great questions here, so we'll go over them in just a second. But if you have any more questions, please go ahead and put in the box here so we can continue to do our Q&A. But in the meantime, if you have feedback for us, here's the QR code. Please scan and give us feedback on how we do here. We would like to improve our future sessions. And the QR code here on the right of the screen, that will take you to our WhatsApp group so you can be informed of our future sessions. I did post a link to our, this is part one of the three-part series with Dr. Armsby. Our second one will be in January 8th at 12 p.m. PST. And I did put a link to sign up for that webinar as well in our link. I just want to give a special shout out to Reina Hussein, who is a neonatologist in Nairobi, Kenya at Aga Khan University Hospital, who is helping us putting together educational materials to go along with this talk as well. These will all be posted in Hard University. So maybe we can go through some of our questions now, Dr. Armsby, if you're okay. One of the questions is related to question number 6 with pulmonary atresia. If you can walk us through what would happen if the ASD is restrictive.
If the ASD is so here's the diagram of that. It's not often that it's restrictive because in utero, this valve is atretic. So blood coming back from the body of the baby as well as blood coming back from the placenta. So that's a lot of volume. That needs to get out of this right atrium. It can go into the right ventricle, but because this is atretic, it's just going to go back and forth through this tricuspid valve. So there has to be a pathway across the atrial septum. And so it's very uncommon to have what you're asking about, a restrictive atrial septum. If you do have that, then you need to do a balloon atrial septostomy to open that up after birth, because truly there's really not much that this baby can do without flow getting across the ASD into the left atrium where it can join the blood coming back from the lungs.
Got it. So it's unlikely that the baby will be have pulmonary overcirculation in that because there's a resistance on the right side with the pulmonary atresia.
The baby can have pulmonary overcirculation. It doesn't have much to do with the atrial septal defect, to be honest. So I think what you're maybe describing is a restrictive atrial septum causing high left atrial pressure, which causes high pulmonary pressures. I think that's what you're describing. But if you're, again, the atrial septum is usually the defect is usually widely patent because blood has to cross from the right atrium to the left atrium all throughout the fetal period.
That's right.
Paul,
Um,
I allowed Mateo Rios, who asked this question, just to come off mute and clarify if that was correctly addressing his question that he put in the chat.
Hello. Yes, partially. I would think in this scenario where you have a patient that has higher saturations, and in the echo you view that the septum is restrictive. You do all the steps that you said, lowering the prostaglandins infusion, and so trying to get the patient to lower lactate, but you keep having a higher lactate, and even though you have the patient under respiratory assistance with the lowering the QP as possible.
Yep.
If the patient keeps rising the lactate, you can suspect that maybe it's the restrictive atrial septum that is somehow complicating the situation of the patient. I don't know. I just was wondering about that. You answer it partially, but I don't know if the reasoning is right, saying like you have a patient that is not getting better, you lower the dose of prostaglandins to minimum, you system ventilate the patient, you blockade so you control all the ventilation, and even though the patient is doing worse, and in the echo you see that the atrial septum is not as you would like it to be, so maybe it's restrictive. You put I don't know if you understand my
okay, Mateo. I do, Mateo. I understand what you're saying, but I think what you're describing is a baby who has an obstructed left-sided physiology. So what you're describing is, I wish I could just put up the picture of hypoplastic left heart syndrome. If the mitral valve was stenotic, the left ventricle was hypoplastic, and the aortic valve stenotic. Let's say that is the issue. And you have a ductus here. If you have pulmonary overcirculation in that situation, you have lots of blood coming back to this left atrium, which is going to become hypertensive if the atrial septum is restrictive. And that will cause a lot of problems, a lot of the problems that you're describing. You're gonna, if you have pulmonary overcirculation and hypoplastic left heart syndrome, you're gonna do the same things. You're gonna decrease the prostaglandin, you're gonna intubate and hypoventilate the patient. You're gonna try to decrease the amount of pulmonary overcirculation. And if that's not enough, then you have to open up the atrial septum a little bit more in order to get blood out of the left atrium and out to the body, basically. But what you're describing, just think of it here. If you have if you have pulmonary overcirculation, that means that blood is going through the ductus into the lungs, coming back to the left atrium, going to the left ventricle and out to the body and round and round. This heart doesn't even need the right atrium. The only thing that the baby needs the right atrium for is it's bringing back blood from the body that crosses over. And you just don't have a restrictive atrial septum very often in this scenario. So, and what you're describing, pulmonary overcirculation, all that excessive blood, you don't need that blood to go across the atrial septum to the right atrium. There's no reason for it to cross this way. So once in a while, you know, I mean, I've been doing this for over 20 years. You have a scenario where you have a right-hearted obstructive lesion and like tricuspid atresia, and you hear that you have to do a balloon atrial septostomy early on. This is tricuspid atresia, so it's a similar situation. But it's pretty rare because in utero, they needed a wide open pathway here. But you are describing a scenario of hypoplastic left heart syndrome where you have pulmonary overcirculation and you're stuck. And my next question was this one. What if you've done that? What if you have pulmonary overcirculation, you've decreased the infusion of prostaglandins, you've intubated, maybe you've even, you know, you're on room air, or maybe you've even widened nitrogen and your FiO2 is 0.18%. We used to do that. If you're really stuck, that's when we go to the cath lab or to the operating room and we control the size of this. We make the ductus smaller so that blood can't, so much volume can't cross the ductus.
Sounds good. Thanks so much for that explanation. And we have
Great
another
question, Theo. Sorry to take so long to answer, but it's a great question.
That's great. We're all about learning physiology here. Now, there's another questions about, actually, this is a great segue for our future sessions on interventional cardiology. In the cath lab, is there an increased pulmonary blood flow? What intervention can you do? And when would you, considering, both interventional intervention with flow restrictor and also surgical PA banding, when would you consider those and what can be done?
Yeah, that's a great question. Okay, great. So looking for our PA band. Yeah. So if you have a situation where you have something like this and you have big VSD or complete AV canal, and you just have so much blood going out to the lungs, you fortified calories, you're on diuretics, and you really need to restrict flow going into the lungs. So what we typically do is a PA band. This is a surgical PA band. These are not easy to do because, sometimes they go on too tight, sometimes too loose. So you're right. There are things called flow restrictors that we can put on into the pulmonary arteries through a transcatheter procedure. The problem is that unfortunately, we don't have a device that's designed for this, where it limits the amount of flow or narrows the blood vessel. That would be beautiful. That would be ideal. Instead, what we have is we have an occlusion device, a plug that we poke a hole into that allows flow to go through the hole. Does that make sense? I hope it makes sense. And so basically we insert a plug in the pulmonary arteries, one on each side, and poke a hole prior to placing the plug in that device, and it allows a limited amount of flow through. And as you can imagine, that's fraught with misadventure as well. The hole might be too small, might be too big, the device might embolize. We really do need somebody to manufacture a flow restrictor that is made for this purpose, rather than sort of jimmy rigging something that does the job.
Perfect. Great. Perfect. And looks like we have one questions, Anastasia. We just let you into the room. If you want to ask your question live, you're welcome to as well.
Hi, can you hear me?
Yes.
Yes.
My question is, when we have these chronic babies with chronic lung disease, bronchopulmonary dysplasia, and they have compensated CO2 retention. So you'll see like pHs of 7.4, but their CO2 lives in the 70s, sometimes on the moment of the day in the 80s. So just really chronic CO2 retention, but their echoes are good, they're thriving, they're on non-invasive support, and we're trying to grow them. Is it safe to grow them and just continue to monitor and not react to the CO2 directly because it's compensated and the kiddos, the echo's stable and the baby's growing? So can we be patient and continue non-invasive support? Or are we putting them at really high risk for pulmonary hypertension that can really get them into trouble one day? Does that make sense?
I caught 90% of that question, and then the last little bit, it broke up for me, and I'm so sorry. I don't know if the problem was on my end, but I heard your question, and I would say yes, in those sorts of babies, you can be patient. Blood is going into those lungs, and it may not, the circulation may not the way I think about it is the circulation may not go through normal lung. And so the blood going in and out may still carry CO2 because it hasn't exchanged that. And the more abnormal portions of lungs, the more likely you are, even though you have flow going through the lungs, because it's going through and not exchanging the CO2, you're going to have a higher CO2 content. And you can't really do much about that. It's not a flow issue, right? It's the lungs working well. And so I think the short answer is yes, be patient with those babies. I think the harder situation happens when you have a ductus or an ASD and a baby like that, and you're stalled. And the question is, is the ASD, is the PDA responsible for the lack of clinical progress? You can't get off high flow, or maybe you can't extubate. And I think this is where really understanding QP and QS and the ratio is important, because a lot of cardiologists will say, oh, it's a small ductus, it's a small ASD. This isn't the problem. The problem is the lungs. The ASD is not why the baby's not progressing. But in the setting of the combination of an ASD and the bronchopulmonary dysplasia, or congenital diaphragmatic hernia, or prematurity, that a little bit of extra flow going through the lungs, or a QPQS of 1.3 to 1 may be enough to cause pulmonary overcirculation, the signs of pulmonary overcirculation. And my point is, I think those babies often deserve a catheterization and a calculation of the QPQS before we write them off and say, or not write the baby off, but write off the fact that the ASD may or may not be an important contributor to the clinical status. In other words, I'm of the opinion that many times a small ASD in the setting of prematurity or bronchopulmonary dysplasia is enough to slow the progress of the baby and does need to be dealt with.
Perfect. And looks like we're short on time. I'll just have one last question here. John B, do you want to ask your question live? Okay, that's okay as well. Looks like that's all the time that we have for today. We will have the second part of this three-part series in January 8th. I hope that you can join us. I did post a link to the sign up right there as well. And if any questions that we're not able to answer live here, we will can reach out to you. All these will be recorded and will be hosted on the Hard University. And so we'll reach out with the rest of the questions that we will not answer live today. Thank you so much, everyone, for joining us. Have a good day.